Well, good Saturday to everyone who's visiting with us today. I'm Robert Kerstein, and I'm here with Dr. Henriette Lerner, one of the world's leading implantologists, and she's also the head of the very prestigious and highly respected HL Dent Clinic and Academy, located in Baden-Baden, Germany. She's also the past president of the Digital Dental Society. She and I have worked together on a number of projects recently, but the most important one that we collaborated on was her digital workflow chapter in the 3-volume Tscan Research Handbook, the Clinical Applications of Computerized Occlusal Analysis in Dental Medicine. And I'm grateful to be with her today. It's so nice to have you with us, Dr. Lerner. Before we get into a discussion of your chapter, I was just curious how things are going with the pandemic in Germany and how dentists are doing during these unique times.
First, thank you so much for having me here. It's a big pleasure, added to the pleasure to have a chapter in your book. Now, of course, we share the same atmosphere as globally. We are working, and we were considered by the German Dental Association like clinical, dental, and medical environment, which are helping people and where people can rely on. Therefore, we respect, safety measures and regulations, which probably you all know, and you respect also there, the social distances, the masks, the shields, and so on. And we try to maintain that trust relationship of the patient, that they can rely on us by respecting all this and keeping them safe from the pandemic. So this is the atmosphere, and we are working.
Well, it sounds like you're fully operational. Here in the United States, dentists are, in some states, are locked down still. Some are able to see emergencies. Hopefully, by the end of the summer, all the dentists will be back in their practices serving their patients. So it sounds like Germany's doing quite well. And Europe has had a challenge. So good luck with the ongoing problem. So it's just amazing what it's done to the entire health community. So
right.
As far as your book goes, as far as our book and your chapter, I just want to tell the attendees, anyone watching, as you post questions, we will address them in the aftermath of the broadcast. So feel free to post your questions, and we will get back to you on Facebook with the answers subsequent to today. So thank you again for joining me. Dr. Lerner's chapter was about the digital workflow and the Tscan. So my first question for you is, how did you get involved with the Tscan? What brought you to be interested in digital occlusal technology?
We acquire and we take into our clinics the technologies which are solving some problems and headaches. And that was my problem 10 years ago, 2010. Where I started to treat more and more full arch reconstructions, not only on implants, also on natural teeth, and started to work with Emax ceramics, and had those patients which needed an increasing of the occlusal vertical dimension and needed to adjust the occlusion. And I realized that with 40 microns articulation paper and with 25 microns, I cannot reach that harmony, and the patient still doesn't feel comfortable. And I started to have those princesses on the P, which all of us have, when we do big reconstructions and we change 3-dimensional parameters. And that brought me to the conclusion that I need something that give me a more detailed analysis and also adjustment, possibility to adjust the occlusion. So that is how I met Tekscan and how I implemented it into the office, because it was at that time, and it is now also the single technology which is offering me these details.
Yes, it's very helpful in case installation, occlusal problems, bite adjustment, post insertion, a huge advantage to the dentist.
Also, after orthodontics, I realized that all the complications, a lot of complications. I was working with an orthodontist, and we realized the recessions, the functional problems, and so on. So it also there is lacking an adjustment, a fine adjustment of the occlusion at the end of the treatment.
Yes, well, it's been shown in some of our Tscan based orthodontic studies that settling does not balance the bite. Settling does not naturally bring about a good end result, even though the orthodontists strongly believe that. These are the kind of the beliefs that have come before the Tscan, that until you could measure between the teeth, these things were unknown. And so this is the kind of benefit that, you know, you're seeing, that just we need, you know, obviously it's a great help to have these kinds of high precision tools at the end of the case. So how did that, oh, go ahead, go ahead.
No, go ahead.
I'm going to ask another question, so please say what you were going to say.
No, I just wanted to add that, of course, additionally, when we have implant supported reconstructions where we have no resilience of the implants, or so no intrusion, we have the titanium base, the zirconia abutments, the emax ceramic, there is a higher necessity of adjustment because the complications is even higher, and might be, and this is actually what we concluded preliminary now, that it can be one of the reasons of peri-implantitis, which is bone loss plus infection, right? And all these arguments made me, you know, implement this technology in a coherent workflow in some stages, because this is how we work in our office. So I don't interrupt you anymore.
No, I appreciate your insight. So yes, it's the problems you addressed are really directly impacted by the Tscan, you know, isolating pressure mapping and showing you high impacts, and you know, it's just, you can't see these things without it. So
Right.
how did it come that you became a collaborator in our Gscan Handbook and wrote your very important chapter on the digital workflow?
I'm asking myself too. No, I mean, I think the beginning point was when we had the opportunity to have a hands-on course with you on our patients. I think that was then the best platform of communication between us for you to see what kind of problems we encounter, and which is our focus in our clinic, and what could be a good contribution with an article in the book from this point of view, from my clinical cases point of view, based on implant reconstructions, full arch reconstructions, immediate loading, immediate placement, immediate loading, and the long-term maintenance.
Well,
I think that was the point where we came together and saw the synergy, right? And yes. I'm very, very honored. Of course, I was surprised and honored to be aligned with all the other authors. And I was always a fan of the first edition. So that's why it was like a present for me.
Well, we were grateful for your contribution, because the digital workflow, as it evolved, necessarily have a digital occlusion component to it. And what stood out to me in your chapter, as we wrote it, as you wrote it, and I, you know, helped you edit it, was that there were so many touch points in the protocol, the digital workflow protocol, that involved the Tscan at provisionalization, to acclimate the patient to their new prosthetic occlusion after all their teeth were taken out. They got all these implants placed. Tscan at case insertion. Tscan, and this was really the unique thing, Tscan at recall. And I had been recalling my prosthetic patients. I'm a prosthetist, so all my prosthetic patients at recall would get these Tscan adjustments to, you know, restabilize the case and minimize long-term issues. So my question for you is, since you have all these points that you use the Tscan in your cases, how did that impact your outcomes compared to when you didn't have the Tscan in all these stages? What kind of differences have you seen?
Mm-hmm. So when I introduce a technology in the office, this is important, and I think this is the approach that we always have. I introduce it in the certain more or one stage or more stages of my workflow. I introduce this in the quality management of my office. And from that moment on, my office and all the team has to follow that new workflow until a new technology comes in and change the workflow again. But that is the structure. So in those I have to mention all the stages because I use the Tscan in the moment the patient comes into the office, because that is a mandatory part of acquiring the digital information in the digital workflow. So except the photographies and so on, before we do the intraoral scan, we make a functional analysis and an occlusal analysis and occlusal adjustment, because this is the stage and this is the situation which we transport actually in all the flow, digital or analog, in to the final result. Then, of course, an workshop will be done, will be after this situation, and provisional will be done in advance, and this provisional will be inserted in the moment of the surgery. Now, no matter how exact and precise you work, this provisional won't be in an optimal and the same occlusal situation as the initial one, especially when we extract teeth and so on. And that's why you do, in the moment of insertion of the provisional, another adjustment of the occlusion, sensor based, because this occlusion, as we know, has to be balanced, because we know that the implants have to have maximum of 150 microns movement, and we know that we have to protect that occlusion and the implants as an infrastructure. So this is the second stage. The third stage would be at the delivery of the reconstruction, because no matter how precise and how precise and accurate are the technologies that you use in milling, printing, also in the guided surgery, you have that distortions, even if they are 40, 60 microns, but are more through the additional distortions of the different technologies. And you need to adjust again the occlusion with multi-bite, laterality movements, protrusion, and so on, which we have different ways of adjusting. And this is well described in all your books and also in this chapter, when you have fully implant supported reconstruction, where the disclosure time is very important. And additionally, when you have teeth and implant supported reconstructions, where you have different intrusions of the parts, and you can measure by seconds the intrusions and the permitted intrusions of the implants versus teeth. So, and the last but not least, and the most important thing, is the maintenance program of the patient, who's coming every 3 months to see if we have a mucositis, because a peri-implantitis wouldn't be reversible, right? And once a year, this occlusion control paired with the decontamination, in order to save on the long time, or to keep the implant reconstructions safe from bone loss and infection on the long term. And under those conditions, we give a longer term guarantee. Now, the actually answer to your question is that, but it's not measurable yet, and this is a subject of our prospective study, which we are now doing in the Digital Dentistry Society, right? A multi-center study, to see, and in a randomized study, what happens, what kind of complications are occurring without Tscan and with Tscan. So as a preliminary observation, I can say, where we were using connections, hex connections on the implant, we had also a lot of screw loosening. Now more and more moving into implant systems which have conical connections, and using zirconia, which is monolithic zirconias, we have less chipping and less screw loosening, but we have the bone loss and the dysfunction and functional problems connected with the situation where we don't use Tscan in the adjustment of the occlusion. So that is what I can tell you now.
So if I understand you in summary, you seem to be having less prosthetic fracture, chipping, screw loosenings with using the Tscan, which is obviously a common problem in dentistry today. The rigidity, as you mentioned, of the implant systems allows for very little occlusal in poor tolerance, and so fracture rates are very high. Some of the reports in the studies, 10-year studies, show 50–60% of the prostheses fracture and break.
Right.
In some way, and you're seeing less of that. So that's very important, obviously. And the more we go into the implant world, the further we explore the capabilities of implants as time goes on, that mechanical problem will persist if Tscan is not used, because carbon paper doesn't measure force and time and pressure and the things you were mentioning about the different intrusions, all very important. So tell me about the research that, well, I know what the research we're doing. So tell the group about the research that we're doing, the prospective analysis about complications, what you're seeing in the early going.
Yeah, that is a prostatic evaluation on randomized cases on implants and teeth by digital occlusal analysis with and without Tscan. That is a 4 multi-center study where, as I said, we take cases, randomized cases where we check all these complications with Tscan. We after the insertion of the final prosthesis, we do a control every 6 months. And the study obviously will take almost 2 years, but we have some preliminary conclusions already. And document and check all these complications which can occur with an analysis and adjustment with Tscan and without the Tscan procedure every 6 months. So that is the study, and we will have an preliminary conclusions already at the consensus conference of the Digital Dentistry Society on the 3rd of October in Serralunga d'Alba in Italy. It will be an not a closed meeting. I mean, it's open for active members, as much people as possible, of course, but it will be on global streaming. So stay online, because we will inform about all the conclusions and preliminary results of all the technologies. There is a consensus about trueness and precision of the technology. So we talk about Tscan, intraoral scans, printers, and so on. So it will be an interesting and very informative meeting for the future.
The study that you're doing, the multi-center study, some of the patients are receiving Tscan at installation and Tscan follow-up. Others are receiving traditional non-digital occlusal.
Exactly. So some of the cases are only with a blue paper with traditional, which is actually last year. You should have used that already. But yes, and the other ones with Tscan, and we have some obvious results in that.
Well, that would be a very important study, obviously, for dentistry if the complication rate is distinctly different with using measured occlusion and Tscan insertion and follow-up in those cases versus those that are adjusted traditionally. So we look forward to those results. When is the consensus conference that you are referring to?
And the 3rd of October this year.
This year. So that would be preliminary results for this.
Right. Yeah. We have only preliminary results because the study will go kind of 2 years in order to have a global, overview about all these aspects. Right?
Yes. Well, I look forward to seeing those results, very much so. Let me ask you, with your vast implant experience, now years in practice, what advice would you give to a young implantologist who might be considering entering the world of digital dentistry and the implant advances that we've all come to know these days? What advice would you give them?
This is a very good question. I think the key of everything is education. Then the young dentists which want to enter dentistry, they are entering digital dentistry and not other dentistry, okay? And they learn in the university, they learn some procedures, but they don't learn concepts, and they don't learn how to implement all these concepts and the techniques that they use in a clinical workflow. That is why they need a structured education once for the dental side, I mean for the digital dental side, but also administrative, organization, communication with the lab, and so on. On the other hand, this structured education should consider the technicians and the doctors at the same time. This is one thing. The second thing would be the optimal constellation would be when the young dentist will step into the senior office and will grow together, will grow into that office 2 or 3 years in order to be able to take this knowledge and to apply the knowledge which started with his structured education. And this is what we offer in the Digital Dentistry Society, the structured education from A to Z. Last but not least, I would advise them at some point when they would want to choose any technologies out there, to choose the ones which solves their problem or make the treatment more minimally invasive, faster, more predictable, shortening the learning curve, and not the ones which are only nice to have or looking nice from a marketing point of view. Yeah. To use those which are really helping, because we have learning curves in our workflow, as you know, so we have to step forward. Those would be the three tips which I would give them.
So along those lines, which of those potential technologies would you say don't have the glitz and gloss, but are the important ones to dentists could consider investing in your experience? Which types of technology are you referring to that would be solving problems versus looking nice on the?
Yeah, for example, we can list a couple of them, but what is mandatory in a diagnosis already, for example, is a cone beam CT. It's a 3D technology of visualization, which I imagine that if the technologies move forward the way it is, the way it's going now, we will use only 3D diagnosis and not 2D, and this is normal because we cannot treat 3D and diagnose 2D. Cone beam CT, then intraoral scanners will need some improvement. So they should also look to the studies which are really offering the real numbers of accuracy and take, the ones which are really obviously an advantage. Generally, intraoral scanning needs improvement, from a general point of view, in full arch reconstructions, in going through the gingiva and showing us the preparation margin and so on. So they have to, occlusal, digital occlusal analysis, of course. That is also my criterias of choosing the technologies, the ones which I needed to have because it solved one of my problems or more problems, or make it more predictable for the future. Techniques of decontamination of the implants, for example, as a prophylactic measure, or technology, or in order to avoid, not to treat the peri-implantitis, to prevent peri-implantitis, where Tscan and decontamination together are a good tool to do that prophylactically. For example, there are a couple of examples only.
Well, decontamination, you're referring to regular cleansing of the cellular area, the peri-implant area, combined with occlusal adjustments to manage the force profile and not overload the implant.
We know that peri-implantitis is bone loss plus occlusion. So we have to take care of all the factors which could cause bone loss. And here we need Tscan mandatorily. Decontamination means elimination of the bacteria. And here you have out there a couple of technologies like photodynamic therapy, like ozone. Everybody takes something, as the studies are different. We are still looking for one tool, or maybe are more tools to that, but use something on a regular basis once a year in order to prevent peri-implantitis, which cannot be predictably treated, only the mucositis. And that is why I need to see the patients every 3 months to treat that if it's necessary.
Well, thank you so much for your important insights and your really important contributions to implant dentistry and to the Tscan Research Handbook. So I'm really glad to have been able to interview you and have you talk to the attendees about what you've learned all these years and how technology has made a big difference in your practice. I really hope you and your family, your staff, your patients all get through the pandemic with good health. And to our attendees, we thank you for spending some of your Saturday with us. As I said, we'll answer the questions that you posted on this live stream in the aftermath. And we really appreciate you taking time to be with us today. I hope you found the conversation helpful in terms of understanding how technology can make a difference in your implant practice. And we wish you a good Saturday, and please stay safe in the pandemic as well. Thank you, Dr.
Robert, thank you so much for mentoring us in the book. Look forward for new publications, common publications, or yours too. And thank you, everybody globally. Stay all safe and healthy. See you soon.
Thank you. Everyone have a good Saturday.
Thank you.